So Victoria is an ONS colleague that's from the University of Pittsburgh, and she works at the BMT Cellular Therapy Service at the University of Pittsburgh Medical Center at the Hillman Cancer Center. She's also the founder and president of Resilient 7, and she has a booth outside that maybe you could check out. And it's a coaching program for nurses to create transformative responses to mitigate burnout, compassion fatigue, and nursing turnover, which kind of follows along with some of the things that Dr. Paramo was talking about. Also outside is a round table with 2 baskets. One says fully vaccinated, and the other says not fully vaccinated. And there's candies on the table. If you would go ahead and put your appropriate candy in the box. It's just something I'm curious about, hoping people will be honest, and I'm sure they will. Okay, so I'd like to turn the program over to Victoria.
So thank you for having me. I was super nervous coming. This is my first big talk, but I said, you know what? We just had this talk about COVID, and I was recently talking to someone about the 3 lessons that I've learned during the past 2 years of COVID, year and a half, 2 years. And my 3 lessons were do the thing, say yes, and then tell the people who are important to you how important they are. So I said yes, so I did the thing today. And I was also excited because when I got that email from Karen that said the theme today was a Jimmy Buffett theme, I also felt so much more relaxed. And so I sent the screenshot, I took a screenshot and I sent it to my partner or boyfriend at home. And if anyone knows John Cordier, he's very just exuberant and a showman himself almost. And so he said, oh, that's awesome. I think I have a coconut bra in our costume box downstairs in the basement. And I said, that does sound tempting, but I think I'm gonna go with your hippo shirt instead. So I'm wearing the hippo shirt today. But I'm not gonna talk about hippo shirts. I'm gonna talk about CAR T-cell therapy, which we've been doing in Pittsburgh. It's also so nice to come to Florida from Pittsburgh. So thank you for this opportunity. And as a disclaimer, just the scope of this practice or this talk is gonna be the current FDA approved products because there are all these products in the pipeline in research. So our agenda, just what are CAR T cells, what are their indications, a little bit about how they're made, how we prep our patients and their intake, the actual infusion, managing the infusion, the 2 main toxicities, CRS and neurotox, a few additional complications, and then how we take care of these patients past that day 28 mark, as well as a little bit about access to care. So CAR T cells are an immunotherapy, and we manufacture them from our patient's own T cells, and it's a genetically engineered way to mount an immune response, and it results in the destruction of cancer cells. Essentially, we call this a living drug, so we hope that they are durable in a patient's immune system over time. They do decrease over time. But across multiple malignancies, including lymphomas, multiple myeloma, and ALL, we're seeing some really significant response rates, at least greater than 30% in really highly refractory disease, which is exciting about this treatment. We don't have a lot of good data yet about how this compares to other standards of treatment, but we are looking into that. So just to kind of give you a good picture to a recent study with refractory diffuse large B-cell lymphoma in patients who had at least 2 prior lines of therapy, they had a CR or a complete response of 40 to 60%, which is very impressive. So this is how we look at the CAR structure. On the outside here, you've got components of the B-cell receptor, and then inside this CAR T cell, you have the signaling domains. And so you have the antigen binding on the outside, and then activation domains intracellularly. Looking a little bit more closely at this antigen binding domain, you're thinking about BCMA for multiple myeloma, and you're thinking about CD20 for lymphomas, and you're activating domains in here as well as the co-stimulatory domains, and we kind of get a little bit further into that. But your CD28s and your 4-1BBs on the co-stimulatory will enhance the proliferation as well as the efficacy and the cytotoxicity even of the CAR T cells, whereas this CD3 zeta is important for the proliferation and the activation of the CAR T cell. These are our FDA approved therapies so far, so I'll run through these a little bit. Abecma is for relapsed refractory multiple myeloma in patients who have had at least 4 or more lines of prior therapy. And so this is an anti-BCMA targeting therapy. Your co-stimulatory and activating domains are 4-1BB and CD3 zeta. For Breyanzi, this is for adult patients with relapsed refractory or diffuse large B-cell lymphoma after 2 or more lines of systemic therapy. This is also not indicated for primary CNS lymphoma, but it's a CD19 targeted therapy, and you can see the stimulatory and activating domains. We've also got Tecartus here for mantle cell lymphoma. It's kind of repetitory. Kymriah for both adults with relapsed refractory diffuse large B-cell as well as young adults up to age 25 with refractory ALL. And finally, Yescarta here at the bottom for a larger group of malignancies with a CD19 target and these co-stimulatory or activating domains. So this is a graphic that you see a lot. This is from Memorial Sloan Kettering Cancer Center, but you have your patient, you'll isolate those T cells through leukopheresis, send those cells off to the lab of the product or the company, and they will then re-engineer them to express the CARs and recognize cancer cells, come back, and we reinfuse them into the patient, and then the magic happens. So the leukopheresis process, you have your patient who's refractory, you decide to take them to CAR T cell therapy. Depending on the manufacturer, this is going to take between 10 to 28 days from leukopheresis to infusion. They undergo leukopheresis using an apheresis machine, which many of us are probably familiar with, to separate these white blood cells from other components. We don't really know the optimal number of CAR T cells that we should be collecting, but current protocols aim for this 5 to 10 range here. And then in addition to that, patients usually require at least a central venous catheter for collection to do that. And because also a lot of manufacturers will require also a minimum lymphocyte count. So you want to make sure your patients have at least a lymphocytes for that. We don't allow steroids immediately prior to this apheresis. And also if they do have, a certain level of disease in their peripheral blood, that's not an exclusion criteria to be leukophoresed. Moving on to manufacturing, like I talked about before, it's in a commercial facility, and this is what they're called, CTCEPs. We use viral vectors to modify the T cells, and these vectors have to demonstrate replication incompetence, meaning they're not going to cause an actual viral infection within the patient, and basically have a low risk of causing some sort of malignancy, but we do screen patients for a minimum of 15 years or monitor them. As far as getting patients from the point of pre-CAR T to be able to have these cells reinfused, you'll often see bridging or salvage therapy to reduce the burden of disease. Often another salvage therapy for patients with ALL or bridging therapy for lymphoma or multiple myeloma. We'll want to choose the least toxic bridging therapy since we're about to also give them lymphodepleting chemotherapy in the case of a lymphoma, and the goal is to control the disease while we're waiting the manufacturing. So for patients with diffuse large B-cell lymphoma, there are a few different examples of that. You can see a combination of Rituxan, polatuzumab, and bendamustine, bendamustine if they've had it previously. And for lymphodepleting chemotherapy, this is specifically, like I said, for lymphoma patients, of course, but also for everyone across the board. But we have to give them this lymphodepletion to create room for the CAR T cells to expand, and also can provide disease control and reduce or eliminate some existing tumor suppressor cells. And so also there's a study that found that giving them this flu-cy lymphodepletion can increase the CAR T cell expansion. And we give this within 3 to 4 days of the CAR T cell infusion, often on an outpatient basis, because most patients are stable enough to get the chemotherapy and then either be admitted for the CAR T, or a lot of centers are doing this both outpatient, inpatient, depending on the patient's disease status. Some examples of Lymphodepleting chemotherapy is just straight cyclophosphamide, etoposide plus cyclophosphamide, or fludarabine and cyclophosphamide. At our center, we use Flu-Cy. I recently had a patient as well who had some pretty bulky diffuse large B-cell lymphoma with a lot of mesenteric involvement as well, and he even had some of this mass was pressing on his biliary tree, and so he had a significant T-bili elevation, well, bilirubin elevation overall, as well as some transaminitis, but even just giving him the lymphodepleting chemotherapy brought down his LFTs to normal and his bilirubin to normal. Let's see, was there anything else I wanted to cover? Yeah. On infusion day, so I remember I was still a bedside nurse when we started doing CAR T therapy at Pittsburgh, and so remember I had maybe our second or third patient, and I infused the cells, and I just sat there and watched, and I was like, what's going to happen next? Because you just hear about the CRS that's going to happen, and everyone was so afraid, but it's really not that immediate usually. But so inpatient versus outpatient depends on their disease burden. We'll do baseline assessments, including the ICE score for their neuro exam, really complete neuro exam as well. We have our neuro-onc team consulted as well. Vital signs, of course. Baseline labs, a CBC or complete metabolic panel looking at their LFTs or LDH. Monitoring ferritin, CRP, lactate, and coags is really important as well, as we'll talk about later with CRS and neurotox. At our institution, we automatically consult critical care to follow. Neuro-onc follows, and so does infectious disease. And depending on your product, you're typically pre-medicating with Tylenol as well as Benadryl. And it's product specific, whether this is an IV bag or an IV push. And each one has their own vital sign monitoring protocol as well, every 5 minutes for 15 minutes, with an additional 30 minutes to an hour there. So looking into these acute toxicities, I'm going to cover CRS and neurotox the most, as well as a little bit about HLH, but some other things to think about. There's a very rare chance of acute infusion toxicity, a lower risk of tumor lysis as well. We do give patients allopurinol coming in with to prevent that from happening. And then a very low risk of anaphylaxis, some coagulopathies, and then cytopenias do occur, so we'll talk about that too. So cytokine release syndrome, it's a systemic inflammatory response or disease. It's a result of just an over-elevated physiologic response that can occur after any immunotherapy involving T cells or other immune effector cells. We're going to have multiple cytokines involved, interleukins, interferon, tumor necrosis factor, et cetera. But it's a good thing, because we have these cells that are growing and proliferating. We're activating all of our immune effector cells to then destroy our cancer cells. But then sometimes this immune response gets a little bit wild. The incidence and severity does vary between CAR T products. It's also going to depend on the patient's disease burden often enough. But you're going to see between all patients, at least 70% of patients are going to have some grade of CRS. And it's often having CRS will indicate if this product is working. It's not the severity itself, but the incidence of having CRS. So CRS signs and symptoms, it's a systemic response. So constitutionally, fevers, rigors, just a general feeling of unwell. Patients are fatigued. They have body aches, joint aches. You also see nausea, vomiting, and headache as well, which some of these symptoms can overlap with a lot of other complications, especially neurotoxicity. You can see a skin rash, like I said, nausea, vomiting, diarrhea. From a respiratory standpoint, they can have an oxygen requirement, they're tachypnic. You'll see a drop in their blood pressure, widened pulse pressure, and just like sepsis, you'll see this early increase in cardiac output and later diminished cardiac output from their shock. Issues with coagulation, an elevated D-dimer, which unfortunately most cancer patients at this point have an elevated D-dimer, but you'll see fibrinogen dropping, bleeding, and possible DIC, renal failure just from the lower perfusion from the shock, liver failure, as well as neuro symptoms, which can be from the CRS or even neurotox itself. So this is something that we have to decide how to treat. The onset of having CRS depends on, like I said, the product, disease burden, and the timing of your T cell expansion. But typically, CRS is going to happen between days 2 up to about 8. It does depend on the product, and it can happen after that. It's just not that it's just you hit day 8, 9, it's just not going to happen. We had a patient who we discharged him on day 8 or 9. The next day, came back with a fever. Grading and management. So each product has its own FDA insert, and within that FDA insert, they do have their own grading system and management protocols. However, there is a consensus grading and management guideline from the ASTT, which I'll share here in a minute. And so the management of this, though, is more based on clinical parameters, not laboratory values. We will, though, watch laboratory values to help us predict what's going to happen. And so like I talked about before, we're going to get a baseline CRP, a lactate, their LDH, look at that ferritin, because as we see these trend upwards, we're going to know that there's a risk of them or a chance of them starting to have CRS. IL-6 is a marker, too, that we know is going upwards, and we end up using tocilizumab to help us manage CRS, but at least at our institution, we don't routinely measure IL-6. And also pay attention to their vital signs, of course, progressive tachycardia, monitor their temperature curve, their blood pressure if they have an oxygen requirement. So we have grades 1 through 4 CRS. Look at their fever first. Grade 1, it's really just a temperature for the most part of 38 Celsius. They may feel unwell, but otherwise they're doing okay. You can manage them with some Tylenol, maybe a little bit of fluid. There's no hypotension, there's no hypoxia. Moving on to grade 2, they do have a fever. They may have hypotension, but maybe they just need fluids. They don't need pressors. In regards to hypoxia, perhaps they're between 1 to 6 liters of nasal cannula. You're progressing upwards, of course, grade 3 and 4. They're going to need pressors. They're going to need high-flow oxygen. They're going to need a face mask, or progressing all the way up to possible needing positive pressure, including CPAP, BiPAP, or ventilation, intubation. And again, this is from the NCCN about managing CRS, and I will just say also a disclaimer, you want to look at your package insert when you are giving these products, but this is a general guideline, and this is a lot of words, so I'm going to get into the main points here. But you'll see, anti-IL-6 therapy, we're talking about giving tocilizumab, and because this is an anti-IL-6 drug, and so if your CRS is prolonged or even an early onset CRS, you're going to consider giving tocilizumab, but really go by your package insert guidelines. As you move forward or more severe with your CRS, you're going to consider adding steroids. You're often giving dexamethasone. As you get more severe, too, you're increasing that frequency and dose from like 10 milligrams every 6 hours. You're going to also give additional supportive care. So even the first sign of a fever, we're going to do a full infectious workup because you can't truly differentiate between CRS and a fever. So broad spectrum antibiotics, we use Zosyn rather than cefepime, and every center may have a different protocol, but since cefepime has a risk of neurotoxicity, we do Zosyn so that we don't confound what we're doing there. IV fluids for hydration, blood cultures, x-ray, urine, all that good stuff, and also look for any signs of infection on your exam. And progress upwards, get your infectious disease team involved. If they are refractory to fluids, we're going to need pressors. We transfer our patients to the ICU. We don't do pressors on the floor at our institution. And use your CCM team to your best of your abilities. One thing I want to mention too is in regards to CRS, sometimes when you have this acute drop in your blood pressure and you're worried about their cardiac status, if we have patients who come in with a high-risk cardiac status, I do ask my ICU team to at least do a bedside echo or get an echo, because sometimes we do see, because of the stress response, an acute cardiomyopathy that is recoverable, but it's good to know about that. And I have to go to my next slideshow because, do you want to do it or want me to do it?
We can do it together.
Okay, I got it.
You got it?
I think so.
Awesome. And then,
You.
yes.
Great. had to break my slideshow into multiple parts because I had too many graphics and pictures. But so differential diagnosis, though, with CRS. So we talked about this can show a lot of different presentations. I mean, you can talk about infection and sepsis. You want to look for additional signs of infections, follow your cultures, treat empirically. Tumor lysis syndrome. So if this is something that we might be concerned about, look at your phosphate, your tumor lysis markers, uric acid, calcium. Hypersensitivity is possible, but this is more minutes to hours after your infusion. So, and this is not usually as common. Another differential is HLH or MAS, which we can talk about a little bit later. But you're looking at fever, splenomegaly, if your ferritin's shooting sky high as well, your triglycerides are up. But we'll talk about that a little bit later. And then a PE, if you have a patient who's, acutely hypoxic and tachypnic, that's something you can think about, but also just needing to think critically here about what could be happening. So I have a little case study. We recently had a 58-year-old female. She had relapsed refractory diffuse large B-cell lymphoma. She had EPOC. She had ICE, multiple therapies, but was still pretty refractory. So we gave her Yescarta. On day 2, she did develop grade 2 CRS, so she had a fever, she had some hypoxia, and she also developed AFib due to the hypoxia and the fever and the stress. So we did give her tocilizumab. She ended up getting 2 doses of toci and fluids. Though her neurological status remained stable. We did an infectious disease workup as well. Her ID workup was negative. She was placed on Zosyn, got vancomycin until her MRSA swab came back negative. But honestly, after these 2 doses of toci and managing her symptomatically, she did very well and was discharged around day 9 or 10, I want to say. The other complication here is neurotoxicity, or ICANS. It's immune effector cell-associated neurotoxicity syndrome. I think ICANS is much more easy to say, so we'll go with that. Occurs as a result of activation of all of these endogenous or infused T cells that we've given, and they interact with our CNS and cause this syndrome. Acute ICANS is common. Delayed occurs in almost all CAR T patients, but it's much less severe. So acute, it usually occurs concurrently with CRS, and you're going to see a decreased attention. They're going to be confused, a little disoriented, some ataxias and delirium. We can treat acute ICANS with tocilizumab. We also use steroids primarily, and we want to be aware of the potential for cerebral edema. And some risk factors for neurotox include CNS disease and also their existing disease burden. So monitoring for neurotoxicity, we're going to use this grading system again, the ICE scoring system. Using orientations, we have 4 points. We'll ask them where they are, what year it is, what hospital are you in, and what month is it. We're looking at their CRP again, their CBC, their metabolic panel, PCINR and ferritin. We're going to have them name 3 objects. So sometimes you have to get creative with people because if you ask them the same thing every day, they're going to say, oh, I'm memorizing that. So I had a patient recently he's an accountant and he's fantastic with numbers. And so this counting backwards from 100 by 10 was just not effective for him. He said, you need to change it up a little bit. So one day it was 6, the other day was by 8, the other day was by 13, but I had to calculate that ahead of time before I went in the room. So you want to make sure that you know they're saying the right thing. Following commands and then writing a sentence, or we have them even write their signature. And so sometimes that sentence is our first really notification, but our first inkling of something going wrong, because they can answer questions well. Maybe they're just a little bit slow. We're waking them up every 4 hours. So I'm not going to be very sprite, either if I've been woken up at midnight and 4 a.m. and all that jazz. But they start writing and then their signature starts to fall off the page or just becomes a scribble. And I've had some patients just put the pen on the paper and just go like this. I'm like, that's not right. So then we have to act. And our nursing is just fantastic. Our nurses are the ones who are monitoring them every 4 hours. I do their ICE score like once or twice a day when I see them during rounds. And so our nurses are fantastic about doing their neuro exams every 4 hours. So here's the ASTCT consensus grading. Grade 1, you have an I score between 9 and 10. They're alert. There are no seizures. There's no cerebral edema. There's a typo. Grade 2, you're between 3 to 6 on your I score. You might need to wake them up a little bit. There's no seizure. There's no cerebral edema at that point. Getting to grade 3 and 4, the ICE score is between 0 to 2. If you're grade 4, this patient can't do their ICE exam at all. You need to wake them up by, vigorously do a sternal rub, etc., something painful. When you're getting to these points too, we're doing EEGs, we're putting them on prophylactic Keppra. You can see some seizure activity. We are getting brain MRIs and CTs as well to look for cerebral edema. So managing this as well, like I said, every institution is going to be a little bit different. There are some judgment calls here too, but consult your package insert. I should just have that on my badge, consult your package insert. But this is an excerpt from one of our notes. We have a section of our note about neurotoxicity monitoring. So monitoring Q4 hours, looking at their baseline ICE score. You may have a patient who comes in and they might not have an ICE of 10 out of 10. They may be more between an 8 and a 9, so it's good to know where their baseline is. We're going to limit our meds that cause any neuro alterations. We don't give them Demerol, even when they're Rigrine, to avoid a seizure risk, unless we obviously absolutely have to. Avoid Benadryl prior to blood products, unless they do have a prior reaction. Avoid benzos, avoid any opiates, or limit opiates if you can, unless they do, have a chronic pain condition. We're not going to withhold any pain medicine from them. And then for grade 2 neurotox or higher, we'll start DEX per protocol. We usually start at DEX 10 milligrams Q6 hours. Consider MRIs with and without contrast, an EEG and LP if it's indicated, and Keppra prophylaxis. And again, these are example managements by grade. You always have to make a judgment call, but grade 1 is supportive care. Ensure they can swallow appropriately. You might want to get your speech consult in there. Consider your MRIs, possible LP, looking at their fundoscopic exam. And then if there is concurrent CRS, they already have any level of CRS, you're going to give TOSI for neurotoxicity as well. Grade 2, just building up. Corticosteroids, and consider an ICU transfer if they start to get worse than any grade 2. Further management, as per grade 2, you're definitely in the ICU. As once you're grade 3, you're going to look for cerebral edema and use your CCM team. Continue to monitor your imaging. And by grade 3, grade 4, they may be intubated. They may not be able to protect their airway on their own. We've got a lot of TOSI. Anakinra is also an option as well if they're refractory to TOSI, steroids, and other supportive care. And then just, again, differentials to consider for neurotoxicity. This could be related to infection or sepsis. An altered mental status can happen when you have sepsis. So we're going to perform a full ID workup. Did they have a stroke? Look at their medications over the past couple of days. They, for some reason, get given too much of some sort of opioid or some other medication that's going to alter their neurostatus. And consider, did they have, unfortunately, a relapse of their CNS disease, or do they already have CNS disease? And look for any brain lesions. Get your LP and look at your cytologies. So this is a patient who, super nice guy, 72-year-old with mantle cell lymphoma, got Tecartus. Initially, his course was really uneventful. He had no CRS, he had no neurotox, discharged him on day 10. You discharge a patient in the morning and then they come back that night. This is what happened. So he was readmitted the same day. At home, he wasn't able to walk. He had some altered mental status and a fever. When he was readmitted, his ICE was 7 out of 10. He had a headache. Initially, his ferritin and CRP were downtrending, so we worked him up. He got a MRI and a CT that was negative. His ID workup was negative. We did do a CSF or a LP that was overall negative too, but we did start him on dexamethasone, just 10 Q12, and then we tapered him with PO prednisone. We never really found any cause other than this must have been some delayed neurotoxicity for this patient. So he was on dexamethasone, Keppra. He did get some empiric-Zocin. He did not get TOSI at this time. However, he kept getting readmitted with altered mental status, ongoing neurological deficits. We were really concerned for an encephalopathy even 2 months after his infusion. And I'm presenting this case because it's not necessarily a case of neurotoxicity, but of confounding factors that look like neurotox. So this was really confusing. We had neuro involved, we had neuro-onc involved. Overall, his neuro workup was negative, including his CSF. All of his infectious studies in the CSF were negative. His imaging was fine for the most part, nothing significant on his EEG. We did place him on steroids and tapered them 3 times. He was on steroids for so long, though, as well, so this was also placing him at risk for infection. The confounding picture was he had a significant rise in his ferritin on his 3rd admission to greater than 5,000. He was febrile, altered mental status was persistent, a little bit of an AKI. Continued to do an ID workup, and at first we were concerned for HLH2, given his ferritin, his fevers. We even did a bone marrow to look for HLH. That ended up being negative, but we found a CMV viremia eventually with greater than 30,000 copies since he was on steroids for such a long time. So treated him for that. He also had a multi-organism bacteremia at some point. So this ended up being more of an infectious picture rather than neurotoxicity. So this is why when you have someone who came in for neurotox before, you put them on steroids, they're at such a high risk of infection that can also look like neurotox. Next slides. Okay. So moving on from the CRS and neurotoxicity, everyone will pretty much end up with cytopenias because we've given them lymphodepleting chemotherapy on top of giving them CAR T-cell therapy, which acts on your B cells and causes a B-cell aplasia. It can be pretty prolonged, but if you do have a considerably prolonged cytopenia, consider getting a bone marrow to look for MDS, relapse, or some sort of hypoplasia. And because of these cytopenias, you're at super high risk for infection. Bacterial, most often early on, increasing risk of viral and fungal infections later. We're just going to give them, of course, transfusion support them through that. Antimicrobial prophylaxis, really good exams. After day 14, at our institution, we do consider giving some sort of growth factor. We consider it safe at that point. We try to avoid that earlier, given the CRS risk with that. And again, for the B-cell aplasia, we'll give IVIG. And I'm going to go into more of our standards a little bit more later, but you're considering as far as antimicrobial prophylaxis, acyclovir, a fluconazole, or some other fungal coverage. Bactrim for PJP prophylaxis. And then at our institution, we do IgG levels or on day +6 to look for hypogammaglobulinemia. Addition to this, we're moving on to HLH2. This is pretty rare, but a severe form of CRS. It's an immune hyperactivation that does happen after CAR T-cell therapy, and we do use the HLH criteria to diagnose it, and I have that on the next slide too in a better image. Typically, and related to CAR T-cell therapy, it will respond to your CRS management, as we've already talked about. If it doesn't resolve, we do follow the HLH guidelines, meaning we'll treat them with dexamethasone, etoposide, et cetera. Alemtuzumab is for refractory disease, and patients who still are refractory may need a stem cell transplant. It can be difficult to distinguish between this and CRS and even neurotoxicity since there are so many overlapping parameters. And then if this is much later, it's separate from CRS. So you're going to treat it as an actual HLH. These are your HLH criteria. From a molecular diagnosis standpoint, this is more often to happen in someone who has a primary HLH not related to CRS. It's more of a pediatric presentation. You're going to look for these 5 clinical criteria, and so you can probably see how we thought perhaps this patient I described before could have had CRS. I mean, he had a fever, he was cytopenic, his triglycerides were elevated, he had an elevated ferritin, and we did send off this soluble IL-2 receptor, but it ended up coming back negative. Clinical manifestations of HLH include this high prolonged fever, which our prior patient did have. You'll see this hepatosplenomegaly or lymphadenopathy, neurological manifestations are pretty variable. It could be focal seizures, a generalized encephalopathy, and confusion. I'm not going to go through all of it for you, but you can see some skin manifestations as well. And then moving on, so we've managed our patient. We did a good job of managing their CRS, their neurotoxicity. Maybe we're tapering their steroids. Sometimes we do discharge patients still on oral prednisone, and we let their outpatient oncologist manage that taper, but they're stable. So we send them out, and we're going to look at their disease response. How often do we monitor them? Infection prevention, looking at how their neurocognitive function is even after therapy, and really I'd like to talk a little bit about patient-reported outcomes because it's something that is really important to their quality of life. And then as far as the disease response, I'll get to that in a second, but this is a wallet card that Tecartus and Yescarta give. Every FDA-approved product has this, but we will go over it with the patient and their caregiver on admission, and then we make sure they have this as they leave, because if they need to come back to an ER or anywhere, they can give this card and say, I've had CAR T-cell therapy, you need to know I'm a little bit special. In addition to that, it does make sure they have a caregiver 24 hours a day for at least 4 weeks after infusion. They must stay within 1 hour of our cancer center if possible. They're also not supposed to drive, operate machinery for 8 weeks after CAR T-cell infusion. And if you have any patients who also enjoy, like hunting and things like that, some of my patients are very upset because I tell them you cannot go hunting. You can, please don't clean your guns even, because I don't know if you're going to get confused. So I'm all for hunting. Trust me, my brother loved to go. I was from West Virginia originally, and so he would come home from college and go hunting every fall. So I have nothing against it, but for these patients, I'd rather them not do it for a little while. And again, no NSAIDs for 3 months with the bleeding risk, and we don't want them to mask any fevers as well. So clinic visits, we're going to look at their disease response. We'll usually get a PET on day 30, and it's going to show really dramatic response. I stole this from a prior study, but you can see all this prior disease burden in this lymphoma patient, and it's essentially gone, which is really incredible. We'll do a bone marrow biopsy, send off a flow cytometry, and you'll want to do a clinic visit at least twice weekly to continue to monitor the lab work that we've been doing. And depending on their oncologist and how they've been doing, we will let them taper off to once a week, every other week, etc. One more. And then physical exam, we have to be super comprehensive about this. We really want our neuro exam to be thorough because there are some subtleties when people are developing neurotox even later that we need to pick up on. You want to do your ICE score. You can even use other tools like the mini mental status exam, but that's pretty time consuming, so stick to your ICE score. A good cardiovascular exam, especially if this patient is one of those that had severe CRS and they had a drop in their EF or their strain. Want to make sure they're doing well there. Look for any infectious complications. I didn't mention this before, but orthostatic hypotension is a common complication due to CRS. We're not really sure why this happens, but help patients understand, maintain your salt intake, maintain your fluid intake to maintain their blood pressure. A lot of patients ended up needing to be prescribed midodrine as well once they're outpatient or even while they're inpatient due to this complication. Again, look at their just general functioning as well, their ADLs, signs of infection, et cetera, and any lymphadenopathy, especially for our lymphoma patients. And then infection and prevention here. We'll give acyclovir up to 12 months, especially because T-cell function is affected for a longer period of time. Continue fluconazole until their ANC is at least 500 to 1,000, and they're off steroids. Some patients may be on steroids for a longer period of time, so we'll consider increasing them to a posaconazole or something with more mold coverage. PJP prophylaxis is typically Bactrim. If we have a patient, who's got some significant renal function, we'll choose another option. At our institution, sometimes even for our stem cell patients, we do monthly IV pentamidine, which isn't really common, but it's what we do. Growth factors if they have prolonged cytopenia, and then a little bit of COVID here. We do flu vaccinations and COVID vaccinations at 3 months. It's unclear how great their immune response is, but we still recommend it. Other vaccination guidelines are a bit more variable until they have a stronger immune function. We'll monitor their CD4 counts as well. And as far as giving IVIG, basically if their IgG is less than 400, that seems to be across the board, looking at what physicians have been doing across the country, well, you can give IVIG. And I talk to patients and their family members about really great infectious precautions, of course, like with any of our other patients, and continue to be very diligent about COVID with their family and in the community. And so some patient-reported outcomes too. We don't really have a lot of research on this, but it's more anecdotal when we see patients who find that they have decreased functional status and they're having a harder time, taking care of themselves and going about their days. And this is something that I think we need to do a better job of doing and using our tools that we have, like these FACT scores, and understanding what patients are experiencing after we've cured their disease, but they still have a lot of trouble going about their day-to-day life. There's a lot of financial toxicity associated with this as well, so we want to use our social workers. They are just fantastic. Their neurological function as well, especially for older adults, greater than 70, there's a risk that they're coming in with a little bit of some sort of dementia or neurological deficit at baseline. And so we've often consulted our geriatric service to honestly help us to differentiate between, is this neurotoxicity, is this a dementia, or have we just exacerbated an existing dementia that we didn't know existed prior to them coming into therapy. And again, look at their performance status. And I like to use a distress thermometer or something like that to make sure that we're giving them a good quality of life after we've given them this therapy. And to shout out to the caregivers out there, like I said, they have to take care of these patients. They've been taking care of their family members or their loved ones for months or over a year prior to this. And now we're asking them to be with them 24 hours a day for at least 4 weeks, and it's often longer after that. And so it's good to involve social work. It's good to involve other people to understand, like, our caregivers doing okay. And they are also just really, really vital to looking at this patient, understanding any of these subtle behaviors that maybe we don't know this patient as well, and so they can pick up on things like that. So I encourage them to be in the hospital if they can. We're lucky where we're allowing 2 visitors total, 1 at a time in the hospital with our patients, so they're at least there during the daytime, not overnight, to help us sort through some things too. And I talked about that too. A little bit about access as well, just to think about. We talked about access to care as far as COVID-19 and our patients who don't have access to healthcare in general or have less insurance coverage, and there's definitely a disparity in who is getting CAR T-cell therapy and who is getting stem cell transplant as well. And so these are things that we need to think about. I mean, do we have CAR T-cell centers that are accessible to people? There aren't that many centers in the country when you consider where you can actually just get chemotherapy. Are physicians referring? Also, just social factors. How old is this patient? Is there a language barrier? Is there a cultural barrier? And do they understand the therapy that they're about to get? And do they have a caregiver? I mean, that can really affect if a patient can get this therapy. I mean, we've even had patients who, they come from 3-4 hours away, and then we're getting ready to discharge them, and they have to stay within an hour, and they're having trouble even paying for the family house to stay in across the street. So things to think about prior to even giving them CAR T-cell therapy. Talked a little bit about economic issues, just even transportation itself. In our healthcare system now, we're seeing a huge shortage in just employees, workers. Trial involvement is down as well, as we talked about before. So just issues that I don't have the answers to exactly, but things that I would like to just bring up and keep us all aware of. And as far as the donor availability, this was something that I struggled with, I didn't struggle with it, but I was upset about during COVID as well. We had patients who were coming in for transplant, and we even put off some elective. It was a while, we considered stem cell transplant to be an elective procedure. And I very much agree, this is a time-sensitive and urgent thing to do, but we pushed back our transplants, we pushed back our T-cell therapy, and hoping that we could just do it in like another month or two. And so unfortunately, we had patients who had disease progression and came out of remission, or their donors developed COVID and they couldn't donate cells. And so I guess it's just a thing for me to say. I hope that we continue to not delay things and we can keep people safe so that we can get them through to therapy. Future directions, CAR T cells is blasting off, basically. That's a really poor analogy, I guess. But we're looking at doing this in a lot of solid tumors now, leukemia, breast cancer, colorectal cancer, various others. The matter is just getting to an antigen that's not going to cause any other problems. So we don't just restrict this just to the tumor. There are a lot of immune evasion mechanisms that these cancers have in their milieu around the cells. We're trying to overcome how to make sure these cells are persistent in the body rather than just dying off. And also just the high tumor volumes. How do we bring down that bulky tumor? And also just what would help with access is how do we increase the amount of centers that we can do this outpatient rather than having to admit people? How do we monitor them well enough? Do we have the right staffing ratios and resources? We also are hoping to get some off-the-shelf type therapy so we don't have to freeze a patient. We can have a donor basically, but then we have to get over the potential GVHD that can occur similar in stem cell transplant. And then a couple of other CAR T design developments that are underway is managing or developing armored CAR T cells. So essentially, in a nutshell, I'm not a microbiologist, but it's a way to get these CAR T cells into the milieu around the cancer and ensure that they can overcome all of these, evading mechanisms around the cancer cell so that we can get to the cancer cell itself and be effective. So I do have a little bit of time for questions, if anyone does have any. Thank you. Sure. Yeah, so same as you would with basically a blood transfusion reaction. We'll give them you want to avoid steroids, but there is an acute reaction. You want to act on that as a life-threatening situation. So we'll give them some steroids, maybe another dose of Tylenol. You can do Pepcid. So just like another infusion reaction with a blood transfusion, similar to that. Also if they're having respiratory distress, address that similar situation. Yes. Sure. So, yeah, and I'll do my very best. I don't work with TILs. We did a couple on our floor, but the TIL therapy is on another service. But the main factors with TILs, you're also using IL-2 to activate those T cells to also be effective. CAR Ts are just infused. There's no concurrent IL-2 to activate them. So that's a main difference here. We're just infusing the CAR T cells themselves. TILs require also IL-2 infusion to go along with them. The CRS is very similar. Neurotoxicity is more unique to CAR T cells, but the CRS profile is very similar. Yeah, thanks. Sure. So originally we did have one nurse practitioner who would see all of our CAR T cells. That was our original plan, who then, similar to our bone marrow clinic, our stem cell clinic, we had the CAR T clinic. Our nurse practitioner would see all of our CAR T patients and then pull their attending physician in after she rounded on them in the outpatient setting. Now our patients will follow up with their attending physician outpatient on initially go to clinic Monday, a couple days a week, or 3 days a week, depending on how they're doing. And then from that standpoint, I'm not very involved on the outpatient side. I'm all inpatient, but it depends on the patient's status, how often the physician wants to follow up with them. But initially, they'll see them at least 2 to 3 times that first week. If they're still doing well, the next week, maybe it's just once, every couple weeks after that. And then they will refer back, if they were in a more of a community setting, back to that referring community oncologist, but still follow that patient every 3 to 4 months too. I hope that was helpful. Oh, sure. So I will touch on Resilient 7 as well. So Resilient 7 is a cloud-based program that I developed, and I kind of have to go back to the story of what happened, how it was made. But I was a bedside nurse for 6 years, and myself experienced a lot of burnout, compassion fatigue, and I was unwell for a little while, let's put it that way. And so I did develop a mentoring program too, because I understood the relationships that I had with other nurses really helped me get through what I was experiencing. I did some projects on burnout and compassion fatigue in grad school, and then the middle of the pandemic, I gave a talk on resilience with 7 concepts to the University of Pittsburgh, and my partner who gave me this shirt is also an entrepreneur, and he saw my presentation. He said, "Vicki, you could create something from this." And I said, okay. And he connected me to a startup in Pittsburgh that has essentially a cloud-based platform where they've been using it to do coaching programs for patients with obstructive sleep apnea, diabetes, et cetera, but the opportunities are endless. So I built one for nurses and developed hopefully for other clinicians eventually. But what it does, it's a 16-week program that guides nurses and in the future other clinicians through these 7 concepts of resilience, and also helps them with professional development, how to talk to mentors, how to developing these mentoring relationships, and how to deal with the burnout, the stress, the trauma they're experiencing. And it's been very timely during COVID-19, of course. But, you know, I think that COVID-19, this burnout existed before COVID, and it just basically ripped the Band-Aid off. And so I think we really need to transform the environment that we have, and this is one way of doing that because it has great data outputs for leadership as well. So we can present, you know, if this is your unit that takes this course or does this program, and you can see all the different categories where your staff or whomever is suffering or doing really well, and we can pinpoint where some solutions could be or where to act. So I'm outside if anyone wants to stop by. And my friend Melissa also piloted the program for me, so she came with me. And I'm just really grateful. So that's our 7. Thank you.